A warm welcome to everyone in the anesthesia class. The topic that we are going to study today is more of a physiology topic. So I'll be dealing with the anesthetic part of this fluid therapy and the various case scenarios that could come in which you have to choose the type of fluid that has to be given to the patient intraoperatively and certain basics of how you are going to give the fluid to the patients. See, what is the main aim of the fluid therapy is the first is to maintain the intravascular volume and the adequate tissue perfusion. The cardiac preload has to be maintained in order to maintain the cardiac output. The oxygen carrying capacity has to be maintained, that is, the hemoglobin level has to be maintained so that oxygen can be delivered to the tissues. Then the coagulation status. If, for example, you are giving a lot of fluid, then dilutional coagulopathy can happen to the patient, which has to be prevented. That is, when you are talking about the fluid therapy, overzealous fluid or hypofluid, both are bad for the patient. Then, in order to maintain the acid base hemostasis, the fluid type, the composition, and the volume which is given to the patient is very important. To maintain the electrolyte balance, that is, hypohypernatremia should not be done. Hypohyperkalemia should be taken care of. The glucose levels, hypoglycemia has to be seen. It has to be seen whether the patient is vomiting, the patient had a history of diarrhea, or what kind of blood loss or what amount of blood loss the patient is experiencing. Then lastly, the surgical losses. In a nutshell, the fluid therapy has to be maintained in order to get a optimal outcome. See, when we talk about the fluid therapy, there are three prerequisites. First, what is the composition of the fluid that we are talking about? Now, how is this going to help you? Every fluid has a different composition. So, as case changes, that is, the surgery changes, so does the fluid changes. I'll give you an example. For example, the case scenario states that the patient is posted for neurosurgery. Now, for neurosurgery, the fluid of choice is normal saline because this is hypertonic and it can lead or it can help in decreasing the cerebral edema. So, this becomes the fluid of choice. Similarly, for example, we have a pediatric patient, say. So, what is the fluid of choice in a pediatric patient? There are two schools of thought for this. One justifies using 0.45% DNS, especially in neonate children. And secondly, in older children, people advocate using isolite P, that is isolite for pediatric patients. Then the volume which is required for the fluid depending upon what kind of surgery they have told. For example, again, we have three kinds of surgeries: minimally invasive, moderate loss, and surgeries in which there is massive loss. So for minimal, in all the calculations, plus we do 3 ml per kg. So whenever there is a calculation of the fluid that is required, we have to be very particular what kind of surgery has been specified in the question. Whether it is a minimally invasive surgery like, for example, fibroadenoma, or the inguinal hernia in which there is minimal losses, or it is a moderate loss surgery. For example, it could be your ileostomy reversal, or it could be your lower limb fracture, etc., in which you have 5 ml per kg of blood loss. Or it could be a massive loss surgery like a exploratory laparotomy for hemoperitoneum, or it may be a intertrochanteric fracture with hematoma, in which you can expect at least 7 ml per kg per hour of blood loss. So the volume of fluid that is required will depend upon which kind of surgery has been specified in your case scenarios. Then the timing, at what time the fluid has to be given, in what time or what ratio, in 1 hour, in 2 hours, or 3 hours. So that depends, because I've already told you over and hypo both are bad for the patient. Lastly, one thing that you all have to be very clear of, and it is asked, is that ultimately it is the plasma, that is the volume of the plasma, has to be maintained in order to maintain the perfusion of the organs. So what is the target fluid? It is the plasma, which is the target fluid in order to maintain the perfusion. What could be the reasons of hypovolemia intraoperatively or preoperatively? First, the preoperative fasting guidelines. I hope you all remember that we recommend that at 2 hours, clear liquids are acceptable and they should be given to the patient in order to decrease the chances of hypovolemia and also to decrease the chances of the catabolic state. 2 hours for clear fluids, 4 hours for breast milk, 6 hours for light meals or non-human milk, and 8 hours for heavy meals like something fried or non-veg food. So all this is very important when we talk about intra-op hypovolemia, because more is the fasting period, more would be the requirement of the patient and more would be the chances of dehydration. Second, mechanical bowel preparation, which these days is done quite less. Bowel obstruction like pancreatitis, which can lead to third space losses. Then the bleeding, maybe the patient is bleeding like pervaginal bleeding is going on. That could be one of the reasons of hypovolemia of the patient. Then coagulopathy, suppose the patient is in sepsis or the patient has been overzealously giving fluid and there is hemodilution leading to coagulopathy. Then hypothermia. Hypothermia per se also disturbs the coagulation cascade, which can lead to microbleeds. Decreased venous return. Like intraoperatively, you have the laparoscopic surgeries in which the venous return is hampered because of the increase in intra-abdominal pressure that can lead to hypovolemia. Positive pressure ventilation or positive end expiratory pressure is being given, which increases the intrathoracic pressure, thus decreasing the venous return and thus decreasing the cardiac output. And lastly, prolonged duration of surgery in which adequate replacement of the fluids has not been done. So these are the one of the most commonest causes of hypovolemia pre and intraoperatively. So I hope the causes of hypovolemia are clear, because generally these causes come like, for example, the patient was is being fasted for the past 10 hours. So what would be the replacement requirement of the patient? So in that you have to multiply the number of hours with the weight of the patient and then equally divide into the hours. We'll come to this later. Then hypervolemia. The hypervolemia of the patient could be that you have delivered a lot of fluid in the patient, which is not balancing the losses. Like for example, you have to take in account the urine output. Okay? So intraoperatively, if you have not taken into account the urine output, then maybe you give hypofluid to the patient. But on the other hand, for example, the urine output is nearly negligible intraoperatively, and you keep on giving fluid irrespective of what is the urine output or what is the blood loss. So maybe you can lead to hypervolemia, and hypervolemia per se itself has a lot of side effects. For example, pulmonary edema. It leads to interstitial edema in the GI system. It can lead to dilutional coagulopathy, and lastly, it can impair your wound healing because it can lead to third space edemas. Then anesthesia factors. Like we always think that before giving spinal anesthesia, we have to preload the patient. But there is a limit to preload the patient also. Preloading does not mean that you have to give 1000 to 1500 ml of fluid overzealously to the patient before giving the spinal anesthesia. It means that preloading has to be done at a speed of 10 ml per kg, which has to be given over 30 minutes to 60 minutes to the patient. Then surgery related. Sometimes you overzealous the blood loss. For example, the blood loss is 100 ml. So you have to replace that with the crystalloid in the ratio of 1.5:1. This is the newer guidelines First, it was 3:1, which the replacement had to be done. But now, what the replacement is that for every 1 ml loss of blood, around 1.5 ml of crystalloid has to be given to the patient. Then the patient who has certain comorbidities associated with it, like congestive heart failure patients who already are in the state of fluid overload. Renal insufficiency patients also have a decreased urine output and excessive fluid in their body. Reduced tissue perfusion. It has been seen, and this is a value that you all have to remember for your MCQs, that when we say that there is a fluid overload in a patient, if the weight gain of the patient is more than 10% above the preoperative weight postoperatively. Immediately postoperative, you take a weight and it is more than 10% of the preoperative weight, then we can imagine that this could be the scene of hypervolemia. The monitoring which is required when you are giving this fluid therapy. There are static parameters, which are your vital organs or your ASA vitals, like blood pressure, heart rate, urine output, central venous pressure, pulmonary artery occlusion pressure, and mixed venous oxygen saturation. All these are your static parameters. Then you have your dynamic parameters, which are meant for your goal directed fluid therapy, which is your pulse pressure variation and your stroke volume variation and pulse wave contour analysis. Then you can have your ultrasound technologies like esophageal Dopplers or echocardiography. And lastly, we can have a surrogate marker in the form of serum lactate, which tells you about the dehydration status. So these are the monitoring, and you have to very well remember that which parameter is a static parameter and which parameter is a dynamic parameter. These are frequently asked these days. Distribution of body fluids, it's more or less a physiological part, but I just want to revise it because this is very important to remember. The total body water. The total body water that a female has is around 50% of the body weight, and in the males it is around 60% of the total body weight. I am talking about the adult male and female. Now, out of this total body water, we further divide it into intracellular, that is 2/3, and extracellular, which is outside your cells, that is 1/3. And the further, what is outside the cells is further divided into plasma and interstitial fluid, of which plasma forms only 20% of the part. So this distribution you all have to remember. The total body water in females is 50% of the total body weight. Adult male is 60%. Out of the total body water, 2/3 is intracellular, 1/3 is extracellular. And out of that extracellular also, 80% is interstitial and merely 20% forms your plasma. When we talk about total body water, the maximum total body water by percentage that is present is in the neonates, followed by 6-month-old or children, then young middle-aged males, middle-aged females, and the least total body water, or approximately the same like females, is that of the elderly. So this is the descending order of the total body water. Neonates, 6-month-old, young children, young male, young female, and lastly, elder population. Now, when we talk about fluids, we have 3 kinds of fluid depending upon the osmolality of the fluid with respect to our plasma. We have hypertonic fluids, in which the colloid oncotic pressure is high or the osmotic pressure is high. The fluid has higher than your plasma, and thus all the water in the plasma Suppose you have given a hypertonic fluid, so there is more of solute here. More of solute has been introduced in your blood, and thus if there is extra water in your tissues, it will move out into your blood, and thus it decreases the edema of the tissues, like cerebral edema. I've already told you about it, that if you introduce something of hypertonicity into the blood, it is going to withdraw the fluid from your tissues and thus leading to decrease in the edema. The hypertonic fluid that we talk about is, for example, you have your NaCl, your RL but with dextrose which has been introduced in it, or 0.5% NaCl but with dextrose. Generally, when we talk about neurosurgeries, what we prefer is 0.9% NaCl. It is isotonic, but it is on the higher side of the osmolality. And the dextrose containing fluids are contraindicated in neurosurgeries. They are least preferred. Okay. Then we have isotonic solutions. Isotonic are your RL solutions or the recently introduced plasma light A. These days, questions on plasma light A are increasing because of its safe profile than ringalactate. They are isotonic fluids. Then hypotonic fluids are generally given in those cases in which we want free water in our body, so that you have water in your blood system. At that time you give hypotonic fluids like 0.45% NaCl without dextrose or 0.25% NaCl when we are deficit in water content, because in this what will happen is the tissues or the water from the blood vessel is going to go inside your cells. Then the main thing that you all have to understand is the differences between the colloids and the crystalloids. See, when we talk about crystalloids, they could be hypotonic, hypertonic, or isotonic solutions, and they are very, very small molecules, and thus they don't stay in the intravascular space for a long time, and they can percolate easily into the tissue membranes, and thus we need a high amount of fluid to replace the losses generally. And the half-life of crystalloids is also less. It is only 30 to 60 minutes. That is why we always tell that if preloading has been asked in spinal anesthesia, that what time, before what time it has to be done. So it has to be completed at 30 to 60 minutes before the surgery. And it should not be like the surgery will start at 10 and you preloaded the patient at 6 o'clock, and now you are saying that yes, it's done, I preloaded the patient at 6 o'clock, but till 7 o'clock all the crystalloid has already been either metabolized or it has gone inside the tissues, and thus the state of the blood vessels or the blood volume remains the same. Then the chances of allergy with crystalloids is very less, and it is very cost effective in comparison to the colloids. The coagulopathic disadvantages of colloids is not seen in the crystalloids. Then when we talk about crystalloids, they are extravascular expanders. They decrease the plasma colloid oncotic pressures, and they're generally used in the cases of dehydration, hypoglycemia, hypochloremias, hyponatremias as a preloading fluid and for the maintenance fluid. In dehydration, you use generally hypotonic solutions or you can use your isotonic solutions. Hypoglycemia, you use your dextrose. Hypochloremia, hyponatremia, you use your NaCl. Preloading can be generally done with RL or plasma light A, and maintenance fluid can be either of the two. When we come back to the colloids, colloids are high molecular weight and thus they remain intravascularly for a long period of time in comparison to crystalloids. They are fast at expanding the intravascular space, and they are at 1:1 ratio to the blood. That is, if 10 ml, 20 ml of blood loss has been there, then 10 to 20 ml of colloid has to be given. There are more chances of allergic reaction using the colloids, but it is coagulation profile is also deranged by the colloids, and it is more expensive also. The excessive use of colloids can lead to cardiac failures, whereas the excessive use of crystalloids can lead to peripheral and pulmonary edema. The molecules of the colloid is very large. We have examples like albumin, hydroxyethyl and your dextrons. The risk of anaphylaxis is very high by the use of colloids. They are very good intravascular expanders because they remain intravasculary for at least 6 to 8 hours, maintaining a good capillary perfusion. Their indication is those cases in which a lot of protein has been lost, like burns patients, in patients where fluid resuscitation has to be given, on especially in those cases in which you have losses at the operative field, but the amount of crystalloid that you can give is also limited. Then in burns patients where you have hypoalbuminemias, or in critically ill patients, colloids can be preferred, keeping in mind the rate of anaphylaxis and the effect of the colloids on coagulation profile and renal profile. Coming to the composition of the fluids, when we talk about the plasma, normal saline, ringer lactate, Hartmann solution, and plasmalite A. These are the main fluids that we use. The composition is a bit difficult to learn. The thing that you all should know is that in plasmalite A, there is a new component introduced, that is the acetate in place of lactate, because lactate was known to cause lactic acidosis, which is absent in the case of plasmalite A. Talking about ringer lactate has all the all the electrolytes also present in it. Other than the electrolytes, the osmolarity of the ringer lactate is more or less similar to the blood, more or less similar to the plasma. The next thing that is important in fluid is how do you calculate or how do you know how much blood has been lost? That is the classes of acute hemorrhage. You have 4 classes of acute hemorrhage, and unfortunately what happens is that when we are able to understand or decide that yes, the patient is dehydrated, or the patient is compensating quite because of the hemorrhage that is going on, etc., the patient is already in the stage of 3 or 4 when he actually starts to develop the symptoms. The blood loss is less than 15%, 15 to 30, 30 to 40, and more than 40% of the blood loss has been classified. When we talk about the pulse, in the first 2 cases, or on the all the 4 cases, the pulse is going to increase in comparison to the blood pressure. That is, the baroreceptor reflex will be activated. Talking about the blood pressure, in 1 or 2 it remains normal, in 3 and 4 it is going to decrease. And similarly, the pulse pressure, the capillary pressure, the respiratory rate is going to increase, and urine output is going to decrease with time. Now, coming to the assessment of blood loss, when you have to assess the blood loss intraoperatively, you have to look at the vital signs. So, any vital sign that is given in your question, you have to tick that vital sign that this is the assessment of the blood loss intraoperatively. Then you have to consider a situation known as the postural changes, like orthostatic hypotension can happen. The patient was lying down and suddenly the patient wakes up and stands and he gets a bit dizzy. That is the orthostatic hypotension of the patient. Then hematocrit can be used. You have a allowable blood loss and the actual intraoperative blood loss that is taking place. For that, you can calculate and you know that this is the amount of blood that the patient can afford to lose before compromising its hemodynamics. Then you can use certain invasive measures like your cardiac output monitoring. Now, coming over to the crystalloids, what is asked in crystalloids is that it is the choice of the maintenance or resuscitation fluid, and the choice right now is ringer lactate, but slowly and steadily, plasmalite A is also being introduced as the initial resuscitation fluid. Done. Then in crystalloids, you have hypotonic solutions, which are generally used for maintenance types, and it has to be given very slowly because if given fast, it can lead to hemolysis. Then dextrose, it is another crystalloid which is given in the cases that you want to replace pure water deficit because it's an isoosmolar. That is, you have to replace if pure water deficiency, then dextrose can be given, especially in children who are prone to hypoglycemia or ketosis. But avoid giving dextrose as the maintenance fluid in all the cases or in the cases of head injury. Done. When we talk about the crystalloids, crystalloids are the initial resuscitation fluids. Please remember this. The initial resuscitation fluid is the crystalloids. Then, other than that, suppose we have loss of water and electrolytes intraoperatively. So, we have now the replacement fluid also. The first we have the replacement fluid, the most commonly used fluid, that is your ringer lactate. What ringer lactate does is, other than giving the electrolytes, it also helps in the conversion of lactate by the liver into the bicarbonates. And thus, this still has an effect on the extracellular composition. Then normal saline. You know, normal saline is sodium plus chloride, 154 sodium, 154 milliequivalents of chloride is present. What happens to normal saline is that it can be used, but it can lead to dilutional hyperchloremic acidosis, which can be corrected if we give bicarb to the patient. That is, NS can lead to dilutional hypochloremic acidosis. Then you have another crystalloid that's 3% NaCl, generally used in the cases when there's last thing that you have to do for the severe hyponatremias. In normal, moderate hyponatremia, if there are no signs or symptoms, sometimes we forego and the patient can be fine by just using its eatables. But when you have a severe hyponatremia, then yes, you have to go to 3% NaCl. Then you have other hypertonic solutions other than 3% NaCl. You have 1.8%, 3% and 6% solutions, and they all are used for the treatment of hyponatremia and plasma volume expansion. And your all others, like for example, it has to be given preferably via the central line because it is very irritant and it can lead to thrombophlebitis. So these are some of the things that you all have to remember. Like for example, it can be asked which is the most commonest fluid used intraoperatively. So the answer will be RL. The most preferred fluid for your neurosurgeries. The answer would be NS. The most preferred fluid for decreasing the intracranial pressure. The answer is 3% normal saline. Most physiological fluid is ringer lactate, but these days one more option can come, that is your plasmalite A. Then in that case, plasmalite A would be the correct answer. Plasmalite A. When we talk about the replacement, I've already told colloid is 1:1 is replaced, whereas in crystalloid in the newest updates it is 1.5:1, that is has to be replaced. I have already told the fluid of choice for the head and neck surgeries is NS, but normal saline should never be used in severe acute hyponatremia. They should be given only when there is hypernatremias. So normal saline should never be given in those patients who have acute hyponatremias. Then talking about colloids, one thing you all have to remember is that all the colloids are isotonic. Colloids are generally isotonic. Exceptions are high molecular weight hetastarches, which are highly osmotic in nature. See, when we talk about the colloids, they are the best replacements before the blood arrives in the OT. Okay, because colloids gives 1:1 replacement of the blood. But please remember, it is just that it is bridging the gap. Colloid does not have the capacity to carry oxygen to the tissues. Done. See, fluid resuscitation in the presence of albumin or conditions associated with large protein losses, such as burns. In those cases, colloids are preferred. The colloids could be natural colloids or synthetic colloids. In natural colloids, you have albumin, 5%, 25% albumin is used, which is heated to 60 degrees Celsius to prevent infections. Okay, you all have to remember this, that at what degree Celsius the albumin, which is a natural colloid, is heated. Then you can have synthetic colloids like you have gelatin, you have dextrons, or you have hydroxyethyl starch. These are the three synthetic colloid that are present. When we talk about dextran, it is a very good volume expander, whereas when we talk about dextran 40, it does decrease the blood viscosity and improves the blood flow through the microcirculations. Then antiplatelet activity has been seen in the patients who are using the colloids with the range of more than 20 ml per kg per day. And the antiplatelet activity of the colloids have to be taken care of. Thus, blood typing, prolonged bleeding time, kidney failures, they all are the side effects of your colloids. Plus, colloids are known to cause the anaphylaxis. I hope I'm very clear. Last, we have hydroxyethyl starch, which is non-antigenic plasma expander, which we derive from plants. It could be high molecular weight, it could be low molecular weight. In high molecular weight, it affects the coagulation system, and low molecular weight can has an effect on that. It can be given as in large amounts because it is safer than high molecular weight HES. And but the hydroxyethyl starch, other than the coagulopathies, it is also known to cause renal derangements. Thus, these are the things that you all have to take care of. For example, the scene has been given that a lot of bleeding is taking place. So in those cases, if you have been asked what would be the fluid of choice, that would be actually your blood. Okay, you have to say that blood is the most preferred fluid at that time. In case the blood is not there in option, go for PRBC as option if whole blood is not in the option. PRBC is also not in the option. What is generally recommended is to use low molecular weight HES, not high molecular weight HES. And if this colloid is not present with you, then replace the blood loss with the crystalloids. Blood transfusions are done intraoperatively. Red blood cells, your plasma, your fresh frozen plasmas, your platelets, they all are transferred to the patient. When we talk about perioperative fluid therapy, how do you actually calculate it? The first thing is that you have to calculate the fluid deficit. You have to calculate three things: fluid deficit, the maintenance, and the replacement part. When we talk about the fluid deficit, it is the weight of the patient into the number of hours of fasting. Whatever you get, now you have to divide this within the first hour is going to get half of this, the second hour is going to get one half of the remaining of the fluid, and so was the third hour. This is the fluid deficit that you have to calculate by calculating the number of hours the patient has fasted into the weight of the patient. Then you have to replace, or you have to give maintenance fluid, not replacement actually. You have to give a maintenance fluid also to the patient per hour. First, fluid deficit, I hope I'm clear. When we talk about the fluid deficit, you have weight of the patient into the number of fasting hours. Suppose the weight of the patient is 40 and the number of fasting hours are 10. So you have 400 ml as your fluid deficit. Done. Now this has to be further divided into the first hour gets 200 ml, the second hour gets 100 ml, and so does the third hour. I hope I am clear. Then the maintenance fluid is calculated using holiday cigar formula. This is the holiday cigar formula which states the 4:2:1 rule. According to this rule, if the patient is, for example, 50 kgs old, this is very important because this numerical does come. If the patient is 50 kg in weight, you divide, like for the first 10 kgs, you are going to give 4 ml per kg, that is 40 ml. For the next 10 kg, you are going to give 2 ml per kg, that is 200. And for the rest which is left, like 30 kgs is left, for 30 kgs that is left, it is 1 ml per kg. This is how you give the maintenance fluid using the holiday cigar formula 4:1. For the first 10 kgs, it is 4 ml per hour. For the next 10 kgs, it is 2 ml per hour. And after that, you have 1 ml per kg. Most commonly used fluid is your normal saline or your Ringer's lactate. And what kind of fluid you are going to use will depend upon the duration of the surgery, the type of the surgery, the comorbidities, and the weight of the patient. It is not going to depend upon the gender of the patient. Now coming over to how much replacement fluid has to be given. We have done fluid deficit. We did the maintenance fluid using the holiday cigar formula, and whatever maintenance fluid come, that has to be added to the fluid deficit every hour. So every hour the maintenance fluid has to be added to whatever is there or in the fluid deficit part. After fluid deficit and maintenance, we come how you have to replace according to the blood that is being lost or the evaporation which is going to take place during the OT period. So how are you going to compensate for that? We have two types of surgeries, minimally and moderately invasive surgery. If this comes, then the replacement is 1 to 2 liters over half to 2 hours. This is how you replace. And if it is a major invasive surgery according to indication, then you can use two strategies. One are the restrictive strategy in which less than 500 ml of the fluid is given. The balanced electrolyte crystalloid solution is given, but it is restrictive. That in these cases of restrictive strategies, we don't overload the patient. That is, preloading is not done. You have to avoid replacement of non-anatomic third space losses, and also the BIS value has to be taken care of, because lesser is the BIS, it would mean that more is the vasodilation and lesser would be the activity of your heart. Okay, so the BIS value also has to be maintained between 40 to 60. And lastly, according to the restrictive therapy, you have to remember the parts or what are the criteria of calling something restrictive. It is less than 500 ml. Crystalloid is to blood, it is 1.5 is to 1. Avoid preloading. Avoid the replacement of non-anatomic third space losses. The BIS has to be maintained above 40, and because you're giving restrictive fluid, so start your vasopressor therapy early in these cases. Then you have goal directed fluid therapy. This word you all have to remember this word because this word is asked a lot these days. It is like giving more than 500 ml of fluid, okay, as the part of the replacement. And intravascular volume status is optimal. First, you have to give fluid and then only vasopressors have to be started, which is very much in contrast to restrictive fluid therapy, in which early initiation of vasopressors is always preferred. Okay. For goal directed fluid therapy, of course, invasive monitoring is required because it is goal directed. It is different for each individual. Done. Then for the goal-directed fluid therapy, our pre-specified goal, this is what you have to remember. The pulse volume variation more than 15% after administering bolus, and stroke volume variation has to be less than 10%. I repeat, if pulse volume variation is more than 15%, fluid has to be replaced to the patient. Okay, and when you have to stop replacing the fluid is when stroke volume variation is less than 10%, or the transesophageal echocardiography shows that a normal LV cavity size is present. I repeat, the pre-specified goals of the goal-directed fluid therapy is that if you have the pulse pressure variation of more than 15%, you have to administer the fluid, the boluses to the patient. But if stroke volume variation is decreased to 10%, it means that LV cavity size is maintained. Done. Lastly, never recommend a liberal fluid therapy. Please remember this for your MCQs also. If this statement comes that liberal fluid therapy should be given, no. That, this concept of giving liberal fluid has been overruled. Then you can have types of blood substitutes. You have to remember that there are two kinds of blood substitutes. One is something that is going to increase the intravascular space, expander, like your colloids and crystalloids. The colloids could be your gelatin, dextrans, or hydroxyethyl, starch, and albumin. Whereas when we talk about the oxygen carriers, these are perfluorocarbons, that is the perfluorochemicals are there, which are based on RBC substitutes. They all are RBC substitutes and they can carry the oxygen and the carbon dioxide much faster than what your blood carries, and they carry this oxygen to the tissues. Then you have hemoglobin based RBC substitutes also acting like oxygen carriers. Talking about perfluorocarbons, because this question has been asked before and they were asked that which of the following lines is correct for the perfluorocarbons. These are fluorinated molecules. What are these? Fluorinated molecules. No toxic metabolites are formed. They're highly soluble, right? And there is no saturation of oxygen and CO2, which is seen in normal blood, but here there is no saturation. The offloading and the preloading both are very, very fast. The oxygen extraction ratio is around 3 times faster than what is there for the blood. Okay, the loading, offloading, the saturation of O2, CO2 never occurs only. The side effects of these perfluorocarbons are, obviously, it is synthetic in nature. It can lead to lung damage, thrombocytopenias, and it can paradoxically also decrease the mean arterial pressure. These are substitutes, okay, blood substitutes. These are not volume expanders, okay. Then one thing that is asked is the changes that comes in stored blood. If you have stored the blood for a long period of time, it can lead to hyperkalemia because of the RBC lysis, hypocalcemia, low 2,3 DPG, and they could be increased in the affinity for the oxygen. Okay, there is increased oxygen affinity, thus that oxygen remains in the hemoglobin, that in the blood that you have transferred, and the offloading of the oxygen is not possible because the 2,3 dpg has decreased, and thus the oxygen hemoglobin curve shifts to the left. And lastly, in stored blood, you have increase in the lactic acid, pH decreases. In these cases, it is well said that in sepsis, kindly use fresh blood, that is the blood which has been withdrawn within 24 hours because of the decrease in the pH, because of the increase in lactic acid. Okay. And lastly, in stored blood, you can have citric acid toxicity also. As you all remember, citrate is present in the blood as a preservative. Done? Then two things I just want to add in the fluid therapy is hypocalcemia and hyperkalemia. See, when we talk about hypocalcemia, in ECG it is asked what kind of rhythm or what changes you see. Prolonged QTC interval is the characteristic finding of hypocalcemia. Then you have tetany, weakness, fatigue, cramps. Two signs, Chopstick sign and Truzy's sign. Chopstick sign says that it is positive when tapping the facial nerve just in front of your tragus, right? It causes the twitching of your facial muscles. And Truzy's signs say that if we inflate the bladder around above the patient's systolic blood pressure for around 3 to 5 minutes, what we get is carpopedal spasm. That is, at the interphalangeal joints you have extension, but at the metacarpophalangeal joints you have the flexion. That is the Truzy's sign. I hope these two signs and prolonged QTC interval are clear to you. Coming to hyperkalemia, you have to see what is the treatment of hyperkalemia. Hyperkalemia is stated when the levels are more than 6.5 millicoulant per liter. The first thing is hyperkalemia can lead to arrhythmias. So we have to stabilize the myocardial cell membrane if ECG changes are present. For that, we use calcium gluconate 10%, 10 ml over 10 minutes. Done. This is how you stabilize your myocardial cell membrane. The second line of treatment is to give insulin plus dextrose solution to the patient. Around 50 grams of dextrose is given and around 10 units of insulin is added to that fluid. Or you can give your 1 millicoulant per kg of sodium bicarbonate in case you have acidosis because of hyperkalemia. Then nebulization using albuterol or salbutamol has also been seen successful in the treatment of hyperkalemia. Lastly, we can increase the excretion of the potassium from the body by giving Lasix or normal saline, or we can go for, if there is a life-threatening hyperkalemia, then hemodialysis also plays a role. Please remember, when we talk about hemodialysis, all the patients can not just enter for hemodialysis. If hyperkalemia, that is the levels of potassium are more than 6.5 millicoulomns per liter, in those cases, and the patient is symptomatically deteriorating, in those cases we can use hemodialysis. Then fluid therapy, the IV cannulas are very, very important part of this. What is asked? The gauge of the cannulas and the flow rate of those cannulas. So let's see, and just hope this diagrammatical representation will make you remember the type of cannulas we have. The smallest of all is purple in color and it is 26 gauge. The flow rate is only 13 ml per minute, and generally it is inserted in pediatric cases that are neonates. You have yellow 24 gauge. The flow rate will go on increasing, but the use of yellow is again in very frail patients or in pediatric patients. Blue, you have 22 gauge, 36 ml per minute. You can say 30 ml per minute, then 30, 60, 90, 180 and 240, depending upon which color are we talking about. See, these are the colors that you all have to remember. If you go to the OT, you can see the cannulas, and once you have seen it, you'll always remember the flow rates and the use for the same. Pink cannulas are generally 20 gauge cannulas. Green are 18 gauge cannulas. Gray are 16 gauge cannulas. And lastly, the largest diameter is that of an orange cannula, that is your 14 gauge with a speed of 240 ml per minute. It's generally used in the cases of massive transfusion protocols. Then a quick recap of the central venous cannulation. What is asked is, at what level does this your central vein cannula has to be placed? So that has to be at the level of the bifurcation of the carina or the T4 level, just above the right atrium. Done. Then what are the indications of central line? You don't have a peripheral line. You have to give vasopressors. You have to start the patient on TPN. For hemodialysis, it is very important. For vasopressors, for transvenous pacing or CVP monitoring, central venous cannulation is very important. It can be done at at three sites. One is your internal jugular, subclavian, or your femoral. When we talk about the internal jugular, the right internal jugular is always preferred over the left internal jugular, because the right internal jugular is anatomically more visible. Plus, it is quite straight also, and it has a predictable anatomical location. And thus, it has a short course before it reaches your superior vena cava. And during the surgical procedures also, it is easily accessible. But when we talk about the complications, IGV, internal jugular vein, could be cumbersome for the patients. So if you want a ICU central cannulation or a cannulation for very long periods with least chances of infections, that is your subclavian. But subclavian cannulation has the maximum risks of pneumothorax. The internal jugular vein, when it is preferred over subclavian, this you all have to remember. First, if there is bleeding diathesis, because what happens is that when you are cannulating the internal jugular vein, every vein has an artery associated. So it is very, very difficult to compress the subclavian artery because it is inserted quite deep, and we don't know the anatomical landmark exactly that this is the subclavian artery, and if by chance we have punctured it, we cannot stop it because where would we pressurize? It is quite deep seated. Then in the patients with severe emphysematous patients also, in which the chances of pneumothorax or the bursting of the bullae, if it is present at the apical, are very high. In those cases also, we prefer the IGV than subclavian. Done. IGV can be used for CVP monitoring. The one thing about CVP monitoring that you all have to remember is the normal measurement of the CVP monitor, which is the normal is 5 to 10 centimeter water or 2 to 6 mm Hg. This has to be remembered. And this is the pictorial representation of your central vein. The normal central venous pressure is that of 5 to 10 centimeter water, or if you convert it in mm Hg, it is 2 to 6 mm Hg. This is the representation of your CVP trace. Okay, please see there are 3 positive and 2 negatives. In positives, you have your A. When does this A comes? If you can see, it correlates with your P in the ECG, and this comes at the time of right atrium contraction. So you have a positive upstroke. Then followed by this, you have another positive upstroke, that is your C. And this C comes when your tricuspid valve, that tricuspid valve enters into your right atrium. At that point, again a positive C comes. Then the right atrium relaxes and the filling of the right ventricle occurs. At that time, you have the X descent. That is, your tricuspid valve has opened, and thus you have the right atrium, which is now giving the blood to right ventricle. Then you have again a positive, that is your V, when the preload is coming back to your right atrium. At that time you have your V. And then again you have a Y when the right atrium starts its emptying phase. So these are the various waves of your CVP tracing. I'll repeat because this is very important to know. First is the A wave. The A wave is the right atrium contracts. Then we have this positive upstroke at the end of the diastolic phase. Of course, when your ventricle is in diastolic phase, the diastolic phase, when it ends, that is then followed by the systolic phase of your right atrium. Done. This systolic phase is lost in the cases of atrial fibrillation and atrial flutter. This is what you have to remember. Then you have canon A waves, which is an MCQ, and this can be seen in junctional rhythms or in third block. Junctional rhythms or third block, you have canon A waves. Then C. The C is at the time of early systole, when your right ventricle is just about to have an isosystolic contraction. At that time, the C goes inside the right atrium and we have a small positive wave that is coming. Okay. The tricuspid regurgitation generally can lead to fusion of these waves also, because if it is regurgitating, so you cannot have that black and a white zone. It's always a gray zone of fusion that is present. Then you have one descent. You have 2 positives, A, C, V, 3 positive, 2 negatives, X. The X is when the right atria is relaxing, okay? But it is not possible in the cases of constrictive pericarditis, in which this X also increases because we have constrictive pericarditis. Then V wave. V wave comes when you have your preload and there is filling of your right atrium. That is your positive V wave. Then Y is the descent, in which you have early diastolic phase, in which the ventricle is filling and atria is emptying. That is Y. Y also is increased in cases of constructive pericarditis or right ventricular failures. Then lastly, we have the peripherally inserted central catheters. For this 4 to 5 points you all have to remember. First, where it is inserted? It is inserted in the basilic vein. Okay. How do you decide upon the length of the peripherally inserted central catheter? It starts from your antecubital fossa to your shoulder. From the shoulder to the right sternoclavicular joint, from the sternoclavicular joint to the third intercostal space. This is asked. What is how the size, the length of the PICC is calculated. Why it is used? It is used to give rapid fluid and it requires less expertise. It is done with using the Seldinger's technique. And the length of the catheter that we get is 52 to 54 centimeter catheter length. One extra edge is that if by chance you have intra-arterial injection, the first sign that comes is pallor. If you remember, we talked about this in our thiopentone class, that if intra-arterial injection is given, sign is pallor, symptom is pain. Goal-directed fluid therapy is the best therapy that has shown good results than liberal fluid therapy. And then you have four kinds of isolites. You have isolite P. If the case of a child comes and the fluid of choice is asked, and isolite P is in the option, so P is pediatric, right? Because it has dextrose and it has a lot of water in it, because I have already told that children have more total body water than adults, right? So isolite P composition is also maintained in a way that you give more of free water to the child. Then you have isolite M. M stands for maintenance fluid. In this, what is extra is over RL, it has dextrose, and again lot of your free water is more in isolite M. It has dextrose. Then you have isolite G. Isolate G stands for gastric, and this is meant for patients who are doing vomitings excessively or they have diarrheas. That is, the gastric fluid is being lost and you have to replace the gastric fluid. Last is isolate E. Isolate E. E stands for extracellular compartment. So these fluids are generally used when we have volume deficit. But one star question here is that isolate E is always contraindicated in the cases of metabolic alkalosis. Okay. And the last fluid that you have to know the difference from RL is plasma light A. When we talk about the plasma light, it is quite a physiological fluid like our plasma osmolality. It is almost the same and also preferred nowadays because of the absence of lactate and presence of acetate in it. Okay, so these were the fluids in which you have to know the total body compositions. Then you have to know what is the difference between crystalloids and colloids and what are the different types, and in what surgery which fluid would be always preferred. Like in burns patient or in patients of hypoalbuminemia, we'll prefer colloids. In neurosurgery, we prefer NS, and we never give dextrose when we are giving a neurosurgery. Then how you have to replace crystalloid is to blood. It is 1.5 is to 1. Colloid is to blood. It is 1 is to 1 replacement. In what cases you have to use your blood or the blood substitutes like perfluorocarbons that have come. Then how do you calculate the perioperative fluid therapy? What is the fluid deficit? What is the maintenance fluid? What is the replacement fluid that you have to give to the patient? Done. Thank you so much for the class.